1, 2,
And review 70-year-old female.
Oh shit, almost got some blood going. Oh, he's wearing it too.
You're in the bay. Once you get over to the bed, we'll give you the story. Everything's going to happen super fast. Welcome to the emergency room.
I lost the pulse.
It's
300 please.
I'll keep you on again.
Pulse check. No pulse.
no more pulse.
Yeah. Where the echo people get? And her blood pressure is off the dropping.
45 minutes of CPR and no return of circulation. Okay.
Welcome to another deep dive. Today we're opening up a pretty massive stack of clinical texts on kidney failure.
Yeah, and for this one, we are acting as your elite ICU intensivists and critical care nursing instructors.
Exactly. We're aggressively applying the 80-20 rule to this material. Yeah. Cutting through the fluff to focus strictly on the pathophysiology, the bedside decisions, and those priority nursing actions that actually save a patient's life.
Right. The stuff that prevents irreversible injury and, well, helps you crush your exams.
So to start, think about a major city's infrastructure for a second. You've got the sanitation department, the water pressure regulators, the chemical balancing systems. They're all just humming along in the background.
Right, keeping everything stable.
Exactly. But when that central processing plant just completely goes offline, the city doesn't just flood. I mean, it literally drowns in its own toxic waste.
Which is, frankly, a terrifyingly accurate picture of what happens when the human kidneys fail. In the ICU, you are never just reacting to numbers on a screen.
No, you have to anticipate the failing physiology.
Exactly. We have to track the cascade from the initial trigger all the way down to cellular death. And our goal today is to arm you with the exact interventions to stop it.
So let's jump right into the most immediate threat. Imagine you're assigned a patient who just rolled in from the ER with massive trauma.
Or maybe they've got severe hypotension from a hemorrhage. They are crashing, and they're crashing fast.
Right. This is acute kidney injury, or AKI. And the 80-20 overview here is that this matters because 1 in 5 hospitalized patients develop it.
Yeah, and if it happens in the ICU, mortality can hit like 80%. It's a rapid, potentially reversible loss of kidney function.
So let's trace the pathophysiology step by step. The trigger is that severe hypotension or hemorrhage.
Right. And the physiologic change is that decreased systemic circulation simply cuts off renal blood flow. That's your pre-renal state.
The organ is basically starving for perfusion.
Exactly. So the compensation kicks in. Autoregulation, you get this massive surge of angiotensin II, aldosterone, and ADH. The body is desperately trying to preserve blood flow and hold on to sodium and water.
But if that ischemia is prolonged, we hit decompensation.
Yeah, the basement membrane disrupts and the tubular epithelium is just destroyed. That's intrarenal damage, specifically acute tubular necrosis, or ATN.
And the clinical findings there are wild. The dead cells slough off and literally plug the tubules. Urine output drops and waste spills right back into the blood.
Right. So moving to assessment. Early on, you see oliguria, which is urine output under 400 milliliters a day.
Wait, you mentioned oliguria for both prerenal and intrarenal. How does a nurse at the bedside actually tell if the kidney is just thirsty or if it's actually dying?
That's a great differential question. Prerenal oliguria reverses with a fluid challenge. You give fluids, they make urine, but intrarenal does not.
Because the tubes are blocked.
Exactly. And pushing fluids into an intrarenal patient can cause deadly pulmonary edema. You have to rely on diagnostics. High-yield labs will show a rising creatinine, which is way better than BUM because it's not affected by diet.
And the specific gravity is fixed at 1.010, right? With a urine osmolality of 300 millimoles per kilogram.
Yeah, which basically means total loss of tubular concentrating ability. The classic assessment findings become fluid retention, bounding pulses, edema,
and late or dangerous findings.
Kussmaul respirations. They're trying to blow off CO2 to compensate for the metabolic acidosis, plus lethargy progressing to seizures from the azotemia.
But the thing that must immediately worry the nurse, the absolute red flag, is peaked T waves on an ECG.
Yes, that means hyperkalemia. For your ADPIE, the highest priority nursing problem is risk for fatal cardiac dysrhythmias.
So priority nursing actions. First, assess ABCs, fluid status, and get that immediate ECG. Next, implement strict fluid restriction.
Right, usually the previous 24-hour loss plus about 600 milliliters for insensible losses. Then, prepare to aggressively treat those electrolyte imbalances and protect them from infection, which is actually the leading cause of death in AKI.
Let's talk medications, specifically for that hyperkalemia. Calcium gluconate the Phe is the most crucial drug here.
It is. An exam trap alert does not lower potassium.
Wait, really? It doesn't move it at all?
Not a single molecule. It raises the threshold for excitation to temporarily stabilize the myocardium. Cardiac muscle hates acute potassium spikes, so this prevents fatal VFib.
Oh, wow. Okay, so we choose that first to buy time. Then we give regular insulin VIV plus glucose to drive potassium back into the cells temporarily.
Exactly. And finally, sodium polystyrene sulfonate or kioxalate to remove it via stool, but do not give that to a patient with a paralytic ileus.
Right, because if it just sits there, you can cause severe bowel necrosis.
Yeah, it's a huge contraindication trap. Now, for deterioration, the patient is getting worse if urine output drops to anuria, mentation worsens, or acidosis deepens.
And for escalation, you notify the provider for falling urine output. You call a rapid response for worsening mental status, but you call a code for peak T waves or a widened QRS.
Exactly. A quick ICU pearl here. Watch out for contrast-induced nephropathy. Never give MRI contrast like gadolinium to a patient with kidney failure. It can be fatal.
And hold metformin 48 hours before and after contrast to prevent lactic acidosis.
Right. So, intensivist thinking here. Problem is trauma. Failing physiology is massive cell death releasing potassium. Immediate threat is VFib. Intervention is IV calcium gluconate. Reassessment is continuous ECG.
Okay, let's lock this in. If you remember only 5 things about AKI. Number 1, core pathophysiology.
Ischemia or toxins cause tubular necrosis, plugging the kidney and halting filtration.
Number 2, key assessment finding.
Oliguria under 400 milliliters a day, accompanied by fluid overload.
Number 3, most dangerous complication.
Hyperkalemia leading to fatal dysrhythmias.
Number 4, priority nursing action.
Struct INO, daily weights, and immediate ECG if potassium spikes.
And number 5, most important treatment.
Calcium gluconate to stabilize the heart, followed by fluid restriction.
Beautiful. So the one-sentence clinical picture is a critically ill oliguric patient with bounding pulses, rising creatinine, and metabolic acidosis who is at imminent risk of a lethal cardiac arrhythmia.
Yep. And if you see peak T waves and a widening QRS in an oliguric patient, think hyperkalemia, and do grab the crash cart to administer 5E calcium gluconate immediately.
Perfect. But what happens when medical management just isn't enough? We have to physically take over the organ's function.
Right. Moving into topic 2, renal replacement therapy, or RRT.
The 80-20 overview is that dialysis moves fluid and molecules across a semi-permeable membrane. You've got intermittent hemodialysis, which is fast and aggressive.
And continuous renal replacement therapy, or CRRT, which is slow, runs 204 C7 and is specifically for ICU patients who are hemodynamically unstable.
Let's hit the pathophysiology. It's basically diffusion and osmosis, right?
Exactly. Toxins move from high to low concentration. Fluid is pulled via osmotic gradients or hydrostatic pressure.
But why choose CRT over standard hemodialysis?
Because HD rapidly shifts fluids. It can crash a patient's preload, dropping their cardiac output and MAP. CRT runs at a much slower blood flow rate, around 150 milliliters a minute.
So it removes fluid by convection without causing that devastating hemodynamic instability.
Exactly. Now, for procedures and assessment, you have to assess the vascular access, usually an AV fistula. You must feel a thrill and hear a bruit.
It's like feeling the vibration of a high-pressure fire hose under the skin. So what if I just need a quick blood pressure reading and that's their good arm?
Absolutely not. Never. That is a massive exam trap. You never take a BP, draw blood, or start an IV in an arm with a fistula or graft. You risk clotting or rupturing their lifeline.
Got it. So during HD or CRRT, priority nursing actions. First, assess fluid status by comparing pre-dialysis weight to the last post-dialysis weight.
Right. That dictates your ultrafiltration rate. Next, monitor vital signs every 30 to 60 minutes on HD and hourly INOs and MAP on CRRT. Then manage anticoagulation like heparin to keep the filter from clotting.
What about complications?
The most common is rapid vascular volume removal in HD. The finding is hypotension, lightheadedness, and severe muscle cramps.
And the nursing action there?
Decrease the ultrafiltration rate and infuse 0.9% normal saline. Do not give hypertonic saline for cramps.
Good to know. And then there's Steele syndrome, right?
Yeah, where too much arterial blood is shunted to the fistula, causing distal ischemia and pain in the fingers.
Okay, so the patient is getting worse if their MAP drops precipitously during HD or if the ultrafiltrate in CRT turns pink or blood-tinged.
And if that ultrafiltrate is bloody, that's an escalation. Suspect a filter membrane rupture, immediate action, Stop the treatment to prevent exsanguination.
So intensivist thinking. Problem is an AKI patient with volume overload needing vasopressors. Failing physiology is they can't tolerate the rapid fluid shifts of HD.
Right. Immediate threat is cardiovascular collapse. Intervention is initiating CRT, and reassessment is checking hourly MAP, ultrafiltrate clarity, and fluid balance.
Awesome. Let's do the 5 things to remember for RRT. Number 1, core pathophysiology.
Dialysis uses diffusion to clear toxins and pressure or osmosis to remove fluid.
Number 2, key assessment finding.
Thrill and brute over a mature AV fistula.
Number 3, most dangerous complication.
Severe hypotension during HD or exsanguination from a disconnected line or ruptured CRT filter.
Number 4, priority nursing action.
Protect the vascular access. No BPs or IVs in the fistula arm.
Number 5, most important treatment.
Decrease the ultrafiltration rate and give normal saline if hypotension occurs during HD.
So the one-sentence clinical picture. An ICU patient on CRRT requires precise hourly monitoring of MAP, hemodynamics, and ultrafiltrate appearance to prevent clotting or cardiovascular collapse.
And if you see blood-tinged ultrafiltrate draining into the CRT bag, think filter rupture and do stop the treatment immediately.
Nailed it. All right, we've handled the sudden crash and the machines. But what happens when the kidney slowly dies over years?
That brings us to topic 3, chronic kidney disease and uremia. The 80-20 here is that CKD is the progressive, irreversible loss of nephrons.
Usually from diabetes or hypertension, right?
Yeah, about 75% of cases between the two. And it's insidious. Patients are usually asymptomatic until their GFR drops below 15. That's end-stage renal disease. At that point, uremia basically poisons every organ system.
Let's walk through the pathophysiology, specifically the CKD-MBD cascade. The trigger is chronic high blood sugar or pressure damaging the nephrons.
Right. The physiologic change is the failing kidney can no longer excrete phosphate or activate vitamin D.
So if there's no activated vitamin D, the gut just stops absorbing calcium, right?
Exactly. Serum calcium drops. The parathyroid gland panics and releases massive amounts of PTH, which literally strips calcium from the bones to compensate.
Ouch. And the clinical findings from that?
Osteomalacia, which is soft bones, and deadly vascular calcifications. The calcium deposits stiffen the blood vessels and the heart. That's why cardiovascular disease is the #1 killer of CKD patients.
Wow. Okay, assessment. Early on, you might see nothing, maybe some polyuria from the diabetes. Classic findings are anemia, stomatitis, and dyslipidemia.
But the late dangerous findings are uremic pericarditis. You'll hear a friction rub and they'll have chest pain. Also uremic frost, where urea crystallizes on the skin when BUN is over 200, and altered mental status.
For diagnostics, GFR is the preferred metric using the MDRD equation. Serum creatinine alone is a pretty poor indicator here, especially in the elderly.
Yeah, because of lower muscle mass. Persistent proteinuria is actually your first sign of damage.
Priority nursing actions. First, rigorous blood pressure control to preserve remaining nephrons. Next, nutrition therapy.
Right. Restrict protein if they aren't on dialysis yet, plus restrict sodium, potassium, and phosphate. Then monitor for infection and bleeding.
Because uremia impairs platelet aggregation.
Right.
They just don't stick together.
Exactly. Now for medications, the CKD cocktail. We give erythropoietin or EPO for the anemia. But the exam trap is that high doses risk thromboembolic events, and it's contraindicated in an uncontrolled hypertension.
And we give phosphate binders like sevelamer. But those have to be given with meals, right?
Yes, strictly with meals to bind dietary phosphate in the bowel. Oh, and here's a crucial trap. Let's say a CKD patient has been on insulin for 10 years, and suddenly the doctor cuts their dose. The patient is confused. Did their diabetes get better?
I'm guessing no.
Absolutely no. As CKD progresses, the kidneys can't excrete insulin. It stays in the blood longer. If you give the normal dose, you will cause severe hypoglycemia.
That makes total sense, but it's so easy to miss. Okay, the patient is getting worse if they develop a pericardial friction rub and low-grade fever, or if they have asterixis, that hand-flapping tremor.
Right, that means worsening encephalopathy. For escalation, you notify the provider immediately for a friction rub because of the risk of cardiac tamponade.
Quick ICU pearl. Do not give magnesium-containing antacids like Maalox to CKD patients. They can't excrete the magnesium, leading to absent reflexes and hypotension.
Yes. So intensivist thinking. Problem is a CKD patient with a friction rub and chest pain. Failing physiology is uremic toxins inflaming the pericardial sac. Immediate threat is cardiac tamponade.
So the intervention is urgent hemodialysis, and reassessment is checking for resolution of the rub and stable hemodynamic.
Exactly. All right, let's run through the 5 things for CKD. Number 1, core pathophysiology.
Irreversible nephron loss leads to uremia, failed calcium phosphate balance, and systemic poisoning. Number 2, key assessment finding.
Friction rub from uremic pericarditis and signs of anemia or bone weakness.
Number 3, most dangerous complication.
Cardiovascular disease and cardiac tamponade from uremia.
Number 4, priority nursing action.
Administer phosphate binders with meals and force strict BP control. And number 5, most important treatment, RRT, like dialysis, or a kidney transplant when GFR drops below 15.
So our one-sentence clinical picture. A chronically ill patient with diabetes presenting with severe fatigue, bone pain, a friction rub, and a GFR of 12 requiring immediate transition to hemodialysis.
And if you see a CKD patient with new onset chest pain and a friction rub, think uremic pericarditis and do prep the patient for emergent hemodialysis to clear the toxins.
Unbelievable. We've covered so much. We started with the sudden lethal crash of AKI and stabilizing the heart from hyperkalemia.
Then we moved to the mechanical lifelines of RRT, focusing on hemodynamic stability.
And finally, unpack the systemic collapse of CKD with all those cascading failures of bone, blood, and the heart.
Yeah, it's intense, but I want to leave you with a final thought to mull over. We've talked extensively about tying patients to complex machines in the ICU, but the sources mentioned the development of a wearable artificial kidney.
Wait, like a miniaturized dialysis machine?
Exactly. Battery-operated, worn on a tool belt. Consider what this means for the future of critical care. If a patient can have their blood continuously filtered 24/7 while walking around the grocery store, how does that blur the line between the ICU and the living room?
That's wild. It completely changes the definition of living with end-stage organ failure.
Right. Keep that in mind next time you see a patient tied to a machine.
Absolutely. Well, that wraps up this deep dive. Keep questioning the physiology, and we'll see you next time.